Hey, what's up everyone? Are you struggling with your EMT assessments? All right, well you're in the right place. We have 3 easy mnemonics that will help you to really nail those medical assessments. So in EMS, we really like our mnemonics, and that's just because of the nature of the job. It might be 3 o'clock, 4 o'clock in the morning, you're on call number 15 of the shift, of a 24-hour shift. It's been 20 hours since you slept, and you're just really struggling to find those words and find things to ask your patients for that medical call or whatever it is. And having mnemonics for us to fall back on are really helpful. If we can remember that simple mnemonic, if we can remember OPQRST, we can start to dissect that and get different questions from that to ask our patients. So we're going to jump into 3 different mnemonics, starting with the one you're going to hear the most, and that's going to be OPQRST. So OPQRST is going to be a mnemonic we're going to use for a patient who has a complaint of pain. We're typically going to hear this in the context of chest pain, but this really works great for any pain. So this could be a trauma patient, it could be a chest pain patient, an abdominal pain patient, whatever it is, as long as there's pain, OPQRST is going to work really, really well. So OPQRST is going to stand for onset, provocation, palliation, quality, radiation, severity, and time. You're just going to have to take the time to memorize that. When I was in EMT school, I made it up like it's almost like a little rap in my head to remember it. So I would tell myself onset, provocation, quality, radiation, severity, time, which is really silly. But it was how I remembered it, and really just the way that you remember these things is the right way, whatever works best for you. One thing that I really recommend for students for these simple memorization tricks is to get a whiteboard. Whiteboard memorization stuff really got me through paramedic school. And I like to have a whiteboard. That way you can write out what you need, and you just erase it and write it again and erase it and write it again and erase it. And if you're doing that, it's really going to help that information to stick in your brain without having to waste paper and worry about all that. So I'm a really big fan of the whiteboard. You can use it for learning your medication dosages, for learning mnemonics, whatever it is. I really recommend new EMTs or students to go get a whiteboard when they're learning these things. Anyways, so OPQRST, like I said, onset, provocation, palliation, quality, radiation, severity, and time. So starting with the O, that's going to be the onset. Now, a lot of the time students or new EMTs, when they hear onset, they're thinking, what time did this start? Now we're going to cover that later in this mnemonic with the T for time. When we're talking about onset, what we really want to know is what were you doing when this pain started? So we want to know if the patient was at rest. We want to know if they were exerting themselves, if they were out for a run, if they were doing some yard work, whatever it is, we need to find out what they were doing when this started. That's going to really help us to differentiate maybe between an AMI or angina, or just to see kind of what was going on when this started. So that O is going to be for onset. When we're asking our patient, it's pretty simple. Sir, ma'am, what were you doing when this pain started? And just see what they tell you as far as what they were doing when this complaint began. Next is going to be P, and that is for provocation or palliation. So provocation is going to be, is anything making this pain worse? Palliation is anything making this pain better. And so that could be everything from a patient who had chest pain while they're out mowing the lawn, coming inside and sitting down, now they start to feel better, that pain is going away, to somebody who has a traumatic injury, and if they move that joint, that pain gets worse. So we need to find that out when we're asking about provocation, palliation. And again, very simple to ask. Sir, ma'am, is there anything that makes that pain any better or any worse? And then you can run them maybe through some range of motion things, have them lift their arms, lift their legs, do those kind of things to see if that helps or hurts the pain, to help you to narrow down what you think is going on. Next is going to be the Q, and that's for quality. And so that is what that pain feels like. Now, if we can, we want to get the patient to describe what that pain feels like in their own words. We don't want to put words into their mouths because we want to get the most accurate information. So when we're asking about quality, ask the patient, sir or ma'am, can you describe what that pain feels like? Use some words and tell me what it feels like. And hopefully they'll be able to describe in their own words what it feels like. If we start to just give them words to pull from, then they're using our words and not their own words. And there might be a case where that's what you have to do. I've had plenty of patients where I say, sir, can you tell me what that pain feels like? And they say, I don't know, it just hurts. It just hurts, I can't tell you. And then you would say something like, well, is it a sharp pain? Is it a stabbing pain? Is it a dull pain? Is it crushing or squeezing? You give them a number of things to pull from and they'll find the one that best fits that. But that's more secondary if they can't come up with their own words to describe it. So R is going to be for radiation. This one's pretty straightforward. Is the pain you're feeling moving anywhere? Did it start somewhere and move somewhere else? Or does it feel like it has an origination point and it goes out from that origination point to a different part of the body? The classic one of this is going to be the patient with chest pain that moves up into their neck or their back or their arm as a sign of a heart attack. Really simple to ask about radiation. Sir, does that pain move anywhere or is it just right there in your chest like you described? You'll usually be able to get some idea if it's moving just based off of a simple question like that. Next is going to be severity. And so that's going to be the scale of 1 to 10. How bad is this pain? I like to give a patient a scale to pull from. So sir, on a scale of 0 to 10, 0 being no pain, 10 being the worst pain you've ever felt in your life, can you give me a number for that pain? Some people like to kind of, break the anxiety of the situation for the patient, bring a little humor by asking it maybe like a silly way. So on a scale of 0 being no pain to 10 being a shark just bit your arm off, where does your pain land there? If you have a patient who has given birth, you might ask that patient on a scale of 0 to 10, 0 being no pain, 10 being childbirth, where does it land in there? So sometimes it can help a patient to give you an accurate number if you give them kind of a scale that they know they can use. Otherwise, ask them 0 to 10. And remember, this is not about us looking at the patient and deciding for them what their pain scale is like. We need to ask them and get that number from them. Maybe it doesn't look like that. Maybe we are seeing other signs that aren't congruent with them having a 9 out of 10 pain. But either way, we need to be able to chart down and track what they are telling us their pain is. So we're going to ask them on a scale of 1 to 10, how bad is that pain? The last one is going to be T, and T is going to be time. So that is when you're going to ask the patient, how long ago did this start? Was it 10 minutes, 30 minutes, an hour, or whatever it is? Again, another pretty straightforward question to ask. Sir, how long ago did this start happening to you? They probably can't tell you, well, it started at 1:52. They'll probably give you 10 minutes, 20 minutes, whatever it is, and then do a little bit of math backwards to get an idea of the time of when this started. When we're talking about time, one other question I really try to ask patients, especially if it's been an extended amount of time, is what has changed from when this started to now to make this a concern? So if I have a patient who tells me they're having chest pain and they've had chest pain for the last 4 hours, why did you call 911 10 minutes ago if this pain started 4 hours ago? Was there a change? Did it get worse? Or what made you make that decision now as opposed to when this first started? Because that can give you some further information to help you decide how critical this patient is or maybe what's going on. All right, so that was OPQRST. Next, we're going to jump into PACE. So like I had said before, OPQRST really only fits for somebody in pain. You can't really ask a patient to tell you if their shortness of breath radiates anywhere. It just doesn't really fit. So OPQRST does have its limitations. That's where PACE comes in for respiratory patients. So for PACE, P is going to stand for provoke, A is associated chest pain, S is sputum production, T is talking tiredness, and E is exacerbation. So jumping into that, the P, when we're asking a patient about the provoke side of things, it'll be similar to what we talked about with OPQRST. Is there anything that makes this any better or any worse? And so we see that fairly commonly with patients, especially when they do something exertional, that it will make their symptoms worse. So maybe an asthma patient that had to walk upstairs to go get their inhaler would report that the exertion of walking up the stairs made their shortness of breath feel worse. Another one we will see pretty commonly is going to be a CHF patient. So those patients, just the nature of congestive heart failure and pulmonary edema, they typically can't lay flat, but they might be able to breathe a little bit better if they're sitting up. So you might ask a patient, if they tried laying flat, and if so, does their shortness of breath get any worse, and if they feel a little bit better when they're sitting up. Next is going to be the A for associated chest pain. This is another one that's pretty straightforward to ask about. Do you have any chest pain with this shortness of breath? Sometimes respiratory complaints are secondary to a cardiac complaint. So we might see a patient who's having a heart attack that also is having some shortness of breath, and this can help us to rule in or rule out some sort of cardiac complaint or to see if there's anything else going on there. So again, really simple. Sir, are you having any chest pain with this, or is it just that your breathing feels difficult? Next is going to be sputum production, and so that's asking about patients if they have any cough, and if they do have a cough, are they getting any sputum out of that? So everybody watching this video at some point has probably had a cold, where they had that nasty chest cold, and when they cough, they spit out some of that nasty, junky sputum, that kind of mucousy stuff that you're getting when you have those chest colds. So asking about that for sputum production is important. And we also want to know what that looks like. Is it a brighter color? Is it a darker color? Is it maybe red tinge, like there's some blood in it? Trying to get an idea that can help you to understand maybe the severity of these things. It tends to seem that the worse a patient has pneumonia or some sort of respiratory infection, the darker the color of that sputum. So if they have a really nasty dark colored sputum, you can be thinking more down the line of some bad pneumonia or something like that. So next is going to be the T, and that's going to be for talking tiredness. Now, if you've been around respiratory patients, you might have seen what we call 2 to 3 word dyspnea. And so that's a patient that, due to them being so short of breath, they can't take in enough air to talk in a full sentence. And so that's when we're talking about the talking side of things. Are they able to get a full sentence out? Or are they clipped with their sentences because they're so short of breath that they don't have enough air in their lungs to talk and get a full sentence out like I am right now? So you're going to be looking for that 2 to 3 word dyspnea. And then tiredness is something else that you'll start to recognize the more time you're out in the field, because we breathe with our muscles, right? Our diaphragm comes down. We use our intercostal muscles. We're breathing with our musculature, and that musculature can get tired. Our diaphragm, all that is used to breathing like you and I probably are right now. But if we are really breathing hard, if we have that increased work of breathing, eventually those muscles will start to get tired. So you might have heard maybe a more experienced EMT or experienced paramedic talk about a breather that's getting tired. And that's when those muscles start to fatigue from having to work so hard to compensate for whatever respiratory complaint is going on, that the patient starts to just have a general malaise or general fatigue look to them, and their work of breathing starts to decrease, even though they should have a higher work of breathing to compensate. So you need to be looking for that in those patients. Do they look physically tired to you? After that, E is going to be exacerbation. That kind of goes hand in hand there with provoke. So provoke, what started this? Exacerbation, what's making it worse, if anything has made it worse. So again, similar to what we talked about OPQRST, you want to find out anything making this any better or worse. All right, so that was PACE. Next, we're going to go and talk about AEIOU-TIPS. Some people might call it vowel tips because AEIOU are the vowels. Either way, we're going to go talk about that one. All right, so when we're talking about AEIOU-TIPS, I'm going to give the way that I usually like to think about it, but there are other words you can associate with these different letters in the mnemonic. You're going to remember it however you remember it. Just keep in mind, the more you can remember, the more it's going to help you to find your differential diagnosis for these different patients. So A in the AEIOU-TIPS is going to be for alcohol, or also maybe arrhythmia. E is going to be for epilepsy. I is infection. O for overdose or oxygen. U, uremia. T, trauma, tablets, and temperature. I is insulin. P, poisoning or psychosis. And S for stroke or syncope. So if we're thinking about this, these are going to be for patients with some sort of neurological complaint, generally. So when we're talking about AEIOU-TIPS, this is going to be a patient typically that has some sort of altered mental status or other neurological issues. So maybe signs of a stroke, those kind of things. We want to be able to run through this list real quick to see if we can find out the reason for those different complaints. And maybe sometimes it looks really obvious like a stroke patient, but anybody who's done this job for any amount of time can probably tell you that either they have or they've heard a story about somebody who took in a stroke patient who was actually just hypoglycemic. So even if the cause of the neuro complaint seems pretty obvious, it's not a bad idea to just run through this list in your head real quick just to make sure that you're on the right track and help confirm your suspicions were correct that it's a stroke or whatever it is. So jumping back to the A for alcohol, that's going to be generally a pretty simple thing. We can ask our patients, maybe ask some bystanders if there's family around. If the patient has consumed any alcohol recently, we can look around the scene to see if we see any alcohol bottles, anything like that. We can also use our sense of smell to smell if we, to see if we smell any alcohol on that patient's breath. Patients aren't always forthcoming about alcohol usage, but it's still something that we want to ask about to see if we can get that information from the patient, and otherwise just use all our senses to try to find that information out. Another thing under A for us to think about is going to be arrhythmia, and so that would be a cardiac arrhythmia. And so hopefully by the time you're getting to AEIOU-TIPS, you've already done a good primary assessment, you felt that patient's pulse to see if they have a regular or an irregular pulse, or if they're in a normal pulse range. Are they below 60, over 100, or are they in that nice 60 to 100 normal range? So hopefully you have already found this information, but somebody with a really significant arrhythmia can maybe show some neurological signs just because they're not getting the perfusion to the brain that they're supposed to. So another thing for us to look for, and it should be another fairly easy rule in or rule out just by checking that pulse. So E is going to be for epilepsy. And so I don't want you to think about just epilepsy, but think about seizures altogether, not necessarily just epileptic seizures, okay? So when we're thinking about seizures, we want to ask if the patient has a seizure history and if there's been any seizure activity noted by bystanders, okay? So sometimes you might not have bystanders around that can give you that information, or maybe not, they maybe not know that information. This is another thing where getting that sample history can be really helpful for you to try to find out if the patient takes any seizure medications. So ask about recent seizure activity, if anybody witnessed anything like that. If they have a history of seizures, maybe they had a seizure that just wasn't witnessed, but we need to try to see if maybe that patient is in a postictal state, which could possibly explain their altered level of consciousness. All right, after the E in epilepsy is going to come the I in infection. And another one that's going to be pretty straightforward. Is the patient possibly working on some sort of infection? Are they septic, or they may be leading towards becoming septic? So there's a lot of different infections a patient can have. Typically, we're going to be looking to see if the patient maybe has a fever. That's going to be one of our telltale signs of infection. Another one that's easy for us to think about is going to be pneumonia, especially right now here in Idaho. It's getting pretty cold because it's just about December. And so, it's kind of flu pneumonia season. And so looking at those lung sounds, listening, see if you have any rhonchi, any of those really junky sounding lung sounds, can help you to think, okay, maybe this patient has some sort of respiratory infection that they're working on. The other big one we want to ask about and think about for infection, especially in our elderly female population that we tend to run on, is going to be urinary tract infections. Very, very common in elderly female patients especially. So we want to ask about recent urinary symptoms. Did they have a foul odor to their urine? Have they been urinating excessively? Have they had painful urination? Is that urine darker in color? Does it maybe have some little floaties in there? If you have the ability to look at the urine, especially if the patient has a urinary catheter, that does have a high prevalence to lead to urinary tract infections. Try to take a look at that urine to see if you see any abnormalities there. But otherwise, we're just going to be looking at infections altogether. Check that temperature, ask about the history to see if maybe there's something leading you to think they have an infection. For the O, we want to talk about overdose first. And that's another one that maybe is not easy for us to find out, but is pretty straightforward. Do they possibly overdose on something? We like to say that the pupils are the window to the brain, And so looking at the pupils is a good way for us to maybe look for an overdose. You know, if they have those constricted pupils, maybe it's an opiate overdose. If they have really big dilated pupils, maybe it's some sort of some sympathomimetic overdose, cocaine, something like that. So we want to be looking for an overdose, and that's another thing that we can kind of use all our senses for. See if there's any smells of anything around, look around you, see if you see any drug paraphernalia, any pill bottles around you, anything like that we can look for. Another one is going to be oxygen. This one's pretty simple. Look at their respiratory state, how is that doing, and then look at their SpO2 to see if maybe they have an SpO2 that's showing they're hypoxic. Hypoxia can lead to some sort of altered mental status symptoms, so look for that as well when we're thinking about the O in AEIOU-TIPS. So the U is going to be for uremia. Uremia is the buildup of toxins and waste products in the blood. And this is usually secondary to a patient who is in a state of kidney failure. So we may see this for patients out who are going through dialysis, especially if they've maybe missed a dialysis appointment. Then they're going to have those waste products building up because they weren't able to go to dialysis to have all those toxins and all that filtered out of the blood. Because if we remember, that's what dialysis does. It takes the place of the kidneys for patients who do not have full kidney function and aren't able to go and process all that out of their body and their bloodstream themselves. So keep this in mind when we're going on those patients who are diabetic or who otherwise are going to a dialysis center. Make sure you're asking them beyond just if they have kidney failure. If they go to dialysis, ask if they've been getting their normal dialysis treatment. Patients commonly will go to dialysis 2 or 3 times a week. They're usually on a pretty set schedule, Monday, Wednesday, Friday, something like that. And if they miss one of those dialysis appointments, all of those toxins that couldn't be filtered out are going to start to build up, and we can see some significant symptoms because of that. So we might see those neurological symptoms. It's not uncommon for patients to have some cardiac symptoms, some arrhythmias, those kind of things. So keep that in mind when we're checking on these patients who maybe are showing some of those signs and symptoms. We need to be thinking about uremia. All right, so the next half of it is going to be the TIPS portion of AEIOU-TIPS, and that's going to start with that T. The first one we want to talk about for the T is going to be trauma. So we want to really specifically be thinking about head trauma with these patients because that can lead to some neurological symptoms. If they're having some bleeding on the brain, something like that, we might see those Cushing triad symptoms showing up, and then we might see some of those neurological symptoms. It could be chest trauma or something like that as well, but we just want to overall look for trauma. So if you come up on a patient who is altered and we don't have any obvious reason for it, look around, see maybe there's a ladder next to them that they fell off of. Do that good secondary trauma assessment. Maybe you'll find some bruising or some bleeding on the scalp that was hidden by the hair, those kind of things to see if maybe that is a reason for this patient to be showing these signs and symptoms. We can also think about tablets when we're talking about the T, and that's going to go right back to overdose. Is it possible the patient overdosed on some sort of tablets? So again, look around, use all your senses, look to see if there are maybe some pill bottles around, some loose tablets somewhere. Try to find that information out and see if you can find out what those tablets are for to see maybe what that patient possibly overdosed on. The last one for T is going to be temperature. Again, right now here in Boise, it's just about December. We've been getting below freezing, especially at night. And so you can see patients showing those severe symptoms of hypothermia or hyperthermia, depending on the environmental situation. So when we're running through this and we still haven't really hit on anything that makes us say like that's probably what's going on, here's where we're going to be thinking about our environmental things. How is it? Is it cold outside, warm outside? And remember, it doesn't need to be that cold for patients to become hypothermic. You might have a patient in a house that's 68 degrees, but if they fell on a tile floor that's cold, they can get hypothermic pretty quickly and pretty severely. So think about that as well when you're doing the assessment and hitting the T on your AEIOU-TIPS. Next is going to be the I, and that's going to be for insulin. And so this is going to be for a diabetic patient and looking at the patient's blood sugar levels. Are they high? Are they low? Either one of those can cause a patient to have an altered mental status or show some of those neurological symptoms. And this is one of those things that you'll probably get in the habit of just checking really early because it's so easy to check for. Just get a little drop of blood, check that blood sugar, and see where that number is. So if you remember, our normal blood sugar range is going to be 80 to 120, but that doesn't necessarily mean that's where everybody's going to live. So if you can find out for a patient who's on the higher side of that or above that, ask maybe what's your normal blood sugar range, because there are patients that live at 200 to 300 every day. So we want to try to remember what that patient's baseline is, or find that patient's baseline, and then judge based off of that baseline how far off from that they are. But a really simple thing for us to do, rule in, rule out, and something, anytime you have a patient who's showing stroke symptoms or something like that, it's really easy for us to knock that out real quick, get that blood sugar level just to rule this stuff out. Coming down to P, we're going to be thinking about poisonings. And so poisoning could be a whole range of things. It could be plants that a kid got into. It could be something airborne. There's all sorts of things a patient can be poisoned by. So this is another thing you just need to really use all your senses for, to look around the environment, see if there's anything there that obviously could be poisoning these patients, and just kind of use that and go from there to find any clues that could be pointing you there. This one's pretty difficult because there's a huge range of different things that can poison a patient and different presentations based off of those things. But again, you're going to be the only one generally in that patient's chain of health providers that is on scene that can do that good scene assessment. So if we're thinking maybe there's some poisonings going on, look around, try to gather that information. Psychosis is going to be another one for P, and that's going to be patient having some sort of mental health crisis that is acting that way because of that mental health crisis. So this one can be pretty difficult to narrow down. You might be able to talk to a bystander or a family member, something like that, to get a history on this patient that would lead you to believe maybe this is due to anxiety or some sort of other mental health issue. So a lot of the finding out psychosis is going to be based off a patient's past history and doing a good sample history to find that information out. For the S, we're going to be looking at stroke and syncope. So stroke, that one's really easy for us to go use another mnemonic. We're going to use FAST when it comes to stroke: facial droop, arm drift, speech, and time. Look to see if we see those stroke symptoms, and that could be what's causing this patient to have those neuro symptoms. Remember, there's a couple different kinds of strokes. There's ischemic strokes and there's hemorrhagic strokes. They're going to present a little bit differently, so make sure you know how to look for both of those things. And then lastly, we're going to be thinking about syncope. And so syncope is going to be that momentary lapse of consciousness, so a patient passing out, essentially. So we're going to be looking to see, did that patient have this altered mental status for a short time and is coming back to normal for us. And so generally, one of our big concerns for a patient who has had a syncopal event is going to be some sort of cardiac arrhythmia or other cardiac issue that caused them to have that short-term lapse of consciousness or to go unconscious or pass out, whatever, however you want to call it. So we need to investigate that once we get down to that S in the AEIOU-TIPS. All right, everybody, that was my top 3 mnemonics for EMTs to really help you to nail those different medical and trauma assessments. Take the time, memorize these things, because like I said before, 3 o'clock in the morning when your brain's just not functioning like it should be because you're so tired, it really helps to have these simple tricks that you can grab onto to help you remember what to do and how to get some good information about what's going on with your patient. Hope you liked the video. Make sure to check the other videos we have out on our page. Hit that subscribe button if you wouldn't mind. It really helps us out. Leave a comment. Maybe tell us what else you want to hear us talk about. We love comments. Otherwise, we'll see you guys on the next one.